So just thinking about in terms of how a healthcare system can operate, perhaps where we are today, it can be a workplace, okay? Or it can be what I'll call a design system, okay? And so a workplace may have a lot of very committed, bright, intelligent people trying to do their best every day. What we're trying to get to, and I think what you all sense frustration around, we're not yet necessarily a designed system that really allows and facilitates those talented, committed people to really do their best work every day. And if you think about the characteristics of the workplace and the characteristics of a design system, that may help to teach us what we might need to do better to move forward. So if you think about the work that we do in a workplace, oftentimes that work evolves. It just evolves over time, right? So traditions last and slightly change, and they just evolve over time, but they're not necessarily designed, right? And a number of you mentioned, okay, well, what was the purpose of this round? To design rounds, we have to first set back and say, okay, well, what are we trying to achieve? Once you understand what you're trying to achieve with that activity, you can start to design it, okay? I'd say in a workplace, the work is organized around tasks. And Paul had mentioned before, oftentimes we look at our work as tasks with obstacles. And so what we get really good at is going around those obstacles so we can go on to the next task. But we don't have that constructive dissatisfaction that Alice talks about. And that's partly because we don't understand our work in terms of processes, right? So constructive dissatisfaction with tasks makes us get around the obstacle to complete the next task. Constructive dissatisfaction with our processes says if there's an obstacle in our process, we have to fix the process, right? We have to make the process work. Healthcare in our hospital requires work to be related among many disciplines. The doctors, the nurses, the floor staff, the lab, the ancillary staff. In a design system, that work would be coordinated, right? There's a designed way that the work is supposed to interrelate. The designed way that the labs are supposed to be available for the floor staff to have ordered it in a coordinated fashion so that everything works in the best interest of our patients. So again, our tasks, our work often evolves out of habits. Can somebody think of what it would come out of in a design system rather than habits? Efficiencies. Essentially that, right? Standards that are well defined to be efficient, right? So rather than, well, we just do it the way we've always done it, we actually define what the standard way to do it is, and then we try to practice to that standard. In our workplace, I think we understand our work and the outcomes in terms of perceptions. Well, I think the care we deliver is great. I think medical education is very good. I think our patients are satisfied. In a design system, how would we assess how good our work, the quality of our work? Metrics, data, right? I'll use that. It would be through measurement, right? Are rounds working? How long did they take? Are our patients actually satisfied? Do we deliver good care? We wouldn't just feel like we know, we would actually measure and know that. In terms of our workplace, our work changing over time, oftentimes it's just adapting to what the next incentives changes, what the next regulatory changes. It's just constantly changing through adapting. If we're a design system that's working well, we're actually learning constantly. And we're learning constantly, again, not adapting based on our perceptions and habits, but we're learning based on measurements and standards, okay? So if you look at these things, they're all very straightforward. I think you would all kind of easily come to these as probably better in many ways than these. But they're challenging to get to, right? There are a lot of things that you need to change to get from here to here. And Paul spoke to this, very important in the workplace is culture, right? We have a very strong culture, and that's something that we don't want to lose. The culture of taking care of every patient as we would our own family member. That's not something we want to lose. And culture is a big, important part of our workplace currently. What would you think the analogous characteristic would be in a design system? You can't come up with an analogous one, probably because there isn't an analogous one. It's the same thing, right? It's culture. Both the workplace and the design system are going to have a culture, but you can see that the culture that arises from this one might be slightly different than the culture that arises from this one. It's not that we want to give up the culture of treating every patient like we would our own family member, but it's how we get to that end is actually very different. It's a little bit what Jill was saying, the language of this culture is different than the language of this culture, and we think that we can actually achieve our goals better through a culture here, okay? And then this is the final concept as we're trying to teach our residents. This is an exercise we did with our residents. Changing culture is not the intervention. Changing culture is actually the outcome of a number of other interventions that we're trying to introduce, and that will change the culture that will make us a better healthcare organization. And that was really the intent of the retreat, is try to teach our residents in going through that exercise. A big part is learning to see. The next part is recognizing how our processes can be better. And the third is really trying to create design systems of care. This is how we think we can get better results for less cost, less suffering, less dissatisfaction. And so I'd say the last and perhaps most important part of our culture, and I think we are learning this as an organization over the past several years, is really recognizing the patient's role, the patient's voice, not only in their own care, but perhaps in how this system is ultimately designed. If we don't recognize the patient's voice, we may actually design a system that doesn't have the right culture.